For a case of urinary incontinence, using our mnemonic old cards, we'll note the onset, or when did it start. For the duration, we want to know if the incontinence is occurring constantly or daily, or is it more intermittent. And if that's the case, we like to note the frequency or the number of episodes. Next, we can note the progression. Does the incontinence appear to be occurring more frequently or more severely? Or if there has been no progression, we'll be sure to include that in our patient note to show that we asked. To help characterize the incontinence, since it is a bodily fluid, we'll use our mnemonic A, B, and C to write down for our patient note the amount, if there's any blood, and the color, and aggravating or alleviating factors. Or if there are none, we'll also be sure to state that for our patient note to show that we asked. In all cases, we can order a genital exam, rectal exam, CBC, serum electrolytes, BUN creatinine, PSA, urinalysis, urine culture, post-void residual, bladder stress test, and urodynamic testing. In a urinary tract infection, our supporting points will include urinary incontinence, dysuria, polyuria, and abdominal or flank pain. And as we'll see in our physical exam coming up, the positive special test for Cva tenderness if in an upper UTI or pyelo, or suprapubic tenderness if in a lower UTI or cystitis. In functional incontinence, we'll have an intact bladder function but an underlying disability. And we'll see a urinary incontinence. Our patient is typically older, greater than 65 years old, with a history of a disability, surgery, sedating medication, or Alzheimer's disease. In overflow incontinence, we'll see urinary incontinence with hematuria, nocturia, straining, a weak stream, and dribbling, all in part from the blockage. And in prostate cancer, we'll see the characteristic weight loss or decrease in appetite seen in cancers. We could also have low back pain with fatigue. In stress incontinence or urethral hypermobility, we'll see urinary incontinence that's aggravated by coughing, laughing, sneezing, exercising, sex, or bending. Classically, our patient will be multipara and postmenopausal. In urge incontinence or detrusor overactivity, we'll see urinary incontinence that's aggravated by caffeine use or stress, with the urge to urinate. In normal pressure hydrocephalus, we'll see the mnemonic wet, wobbly, and wacky for urinary incontinence, gait disturbance, and a confusion or memory loss. And we'll add to our workup a CT of the head. In transverse myelitis, we'll see urinary incontinence, a myelopathy from the myelitis below the level of the lesion, and since it's a myelopathy, it will be a bilateral radiating pain, sensory loss, and motor weakness. We could also have a history of a recent URI or gastrointestinal infection serving as a nidus for the autoimmune disease. And we'll add here an LP of the CSF and an MRI of the spine. In Guillain-Barre Syndrome, we'll see urinary incontinence with extraocular movement defects or a facial nerve palsy. We could also have sensory loss, particularly in the lower extremity, and an ascending paralysis starting again in the lower extremity. The deep tendon reflexes can be delayed. And we could also again have a history of a recent URI or gastrointestinal infection serving as a nidus for the autoimmune disease. And finally, in multiple sclerosis, we'll see urinary incontinence, diplopia or vision loss, numbness, tingling, motor weakness, ataxia, aggravated by warmth and Uthoff sign. We can see internuclear ophthalmoplegia and or Lermite sign. And we'll add here for our workup an LP of the CSF, an MRI of the spine, and now brain. Okay, we'll start our abdominal exam with a hand sanitizer, and we want to ask our SP if we have permission to examine you while he's still sitting up to the cardio exam to get that out of the way. So the best way to do this here is again to lower the gown slightly and to ask them to please sit and hold it like this. This will protect them and keep them covered up. We want to verbalize that we don't see any visible lesions in the anterior chest, no visible lesions to the posterior chest. We'll go ahead and palpate and see if he has any chest tenderness. So please let me know. Any pain. Okay. Do the same thing on the back. Next thing we can do is auscultate for his heart sound, and so we'll use the mnemonic apartment M225A, and we'll listen first in his right intercostal for the aortic, and we'll go over to the left for the pulmonic, and then we'll go to listen to the tricuspid. And now for mitral, if this was a female, a good tip is to ask him to please lift up your upper breast. You could comment that we hear an audible S1, S2, regular rate and rhythm, no audible S3s, S4s, or murmurs, rubs, and gallops. Once we completed the cardio, we could transition nicely to
home exam while he's still sitting up, and so we could go ahead and percuss. We'll start above his clavicle, comparing left to right. And we're going to go ahead and do the same thing on the back, 3 spots. We could auscultate again, and we'll start above the clavicle. We're going to use the bell first. Please take it, and the instructions you want to give, so please take a deep breath when you feel my stethoscope. Please take a deep breath in and out. Okay, compare left to right. Do the same thing on the back now. Okay, then we could verbalize again that it was cleared auscultation, no audible wheezing. Once we concluded the cardio and pulm exam, we could cover him up again. Now we can instruct him, I'm going to now lie you down to do the abdominal exam. Is that all right? Okay, so we want to help them down. And you don't want to forget to extend the legs for the leg rest. Now you could rest your legs. For the abdominal exam, they'll have a gown here, and you want to move it up all the way to their pelvis, and then you want to ask permission to take it up. We want to do the same step again. We want to first verbalize that we see no visible lesion. First, ask if he has any pain anywhere.
Yeah, just right here.
A little pain on the upper right side? Okay, so now we're going to go ahead and start on the opposite side on the lower left. So, okay. And go to the right. Okay, we could verbalize that there were normal active bowel sounds. He had pain on the upper right. We'll start on the lower left. Normal resonance to percussion. Now we're going to go ahead and palpate. So the tip for this is for superficial first. We're just going to use one hand, and we're going to start on the lower left. And you want to make good eye contact to see if he winces at all, or let him know if you have any pain. If we're concerned for cystitis, we would want to assess suprapubic tenderness. And so we will expose the area, and we'll assess his suprapubic area over here by palpating. And if he has pain, he'll let us know. Do you have any pain?
Yes.
Okay, so now we would be concerned for cystitis. 3 quadrants on the bottom, 3 middle quadrants, 3 upper quadrants. Okay, and then we could have good confirmation that he was in pain. Now for deep, we just want to place our second hand on top and do it again. Okay, so we could get a little pain there on deep. Once we complete a deep palpation, we want to go ahead and check for hepatomegaly. So the best way to do this is to place your hand under the border of his liver. You want to instruct the patient to please breathe in. And then as he breathes out, you can breathe out now. You want to go all the way up into the lower rib cage, and as long as you don't feel the liver extending below, you can verbalize that there was no hepatomegaly. And you can do the same thing for the spleen. So again, please breathe in, and now please breathe out. Okay, and you can feel the lower left rib, and there was no spleen coming down.
Okay, and very important for a case of lower abdominal pain, if we're concerned of nephrolithiasis or pyelonephritis, to check for kidney pathology, we're going to assess Cva tenderness. So to do this, we very simply make a fist, and we could ask them if they have any pain when they tap. We'll do left. Do you have any pain here?
No.
Okay, and then we'll assess the right as well. Do you have any pain there?
Yes, I feel.
So now he has positive, we're concerned for renal pathology on his right side.